Hello and welcome. And today I'm very pleased to introduce Dr. Rosalind Simpson. Rosalind is a consultant dermatologist at Nottingham University Hospitals and Associate Professor at the Centre of Evidence-Based Dermatology. She is a general dermatologist with specific clinical and academic interests in women's health and vulval dermatology. Welcome, Rosalind. Ros.
Thank you very much for having me here today.
So the reason we're talking to Ros today is around Lichen Sclerosus. Now, Ros has worked or is working on 3 different projects at the moment concerning this condition, and it's something that we're particularly interested in and have always been supporting at Talk Health. And Ros is going to talk to us today about the project she's working on, and definitely it's a call out for people if they're interested to go and click on the links, which we'll talk about at the end of this discussion, to see if this trial may be something of interest to them. But Rosalind, let's have a quick chat about you and your specific interests in these areas.
Thank you. So I work as a consultant dermatologist in Nottingham, but I also work as a researcher at the University of Nottingham. So my job is a dual type of role, and that means that I'm a clinical academic. And through having these 2 different streams to my job type, it means I get kind of a unique insight from the researcher perspective, because I'm actually working in the clinics with the conditions for the people we're trying to help. So I kind of see both sides of the coin. And I have been working as a consultant for 6 years now, and I have a particular interest that's developed over the years, and indeed when I was training, into women's health and vulval skin conditions. And these are conditions that really aren't very well known about. And I think that was the impetus for me to undertake more research and to find out more about them, because I felt that the group of women that were coming through clinics with these types of conditions were really underserved and really underheard in terms of the symptoms and signs of the problems that they were presenting with. So I work as a general dermatologist as well. I see general skin complaints, I see skin cancers, I undertake skin cancer surgery. But my main particular area of interest that I'm developing, as I've said, is this area of women's health and vulval skin conditions. So alongside my research and clinical side of things, I also work voluntarily with the British Society for Vulval Disease, which is a national society with health professionals from across the country looking to improve knowledge base and research within these conditions as well. Thank you.
And I was just going to say that I think I mean, I don't, tell me if I'm wrong, but it's quite unusual for academics to also be working directly with the public. And I think it really brings a real perspective, because you are really understanding what is happening with these people and the research you're doing, the difference that you know that it can make to people.
That's right. As I said, it's a real unique insight of being on the front line, seeing patients in clinic, hearing their stories, understanding their struggles and difficulties getting to the right place to get the right treatment. So it does mean that I've got that real focus with the research that we're doing that is driven by the patient experience. And the other thing to mention is that patient and public involvement, so having their opinions and voices feed into the research that we're doing, really helps shape a project and helps the development of it, such that the research that we are undertaking is really relevant to patients and that it's acceptable to them as well. So
Yeah,
really 3 different strands: of the clinical, the academic, and there's the patient involvement in what we do.
So can you quickly just give me an idea, because we know it's not the most commonest condition for people, and also for women. We also know that it is underdiagnosed and takes a long time to get a diagnosis.
That's right. For some people, the pathway to diagnosis can be really very long. Lichen sclerosus is quite a distressing condition that affects genital skin predominantly, and it is much more common in women than it is in men, although it does affect the genital skin of men.
Right.
It can affect children too, so girls and boys can be affected by this condition. Within females, it's believed to affect around 1 in 100 women. So it's not as uncommon as what you might initially think. And there are some studies that have shown that in older women, particularly 80 and above, it can affect up to 3%. So this is more of a common problem than we realise, that isn't necessarily presenting due to a number of reasons. And lichen sclerosus is caused by really quite intense inflammation in the skin. And it affects the genital skin, as I said. In the women, it affects the vulval area. And the vulva is the skin, it's the area that surrounds the entrance to the vagina. So lichen sclerosus doesn't actually affect the vagina itself, it affects the skin surrounding. And the inflammation causes really intense itching and discomfort. And the fragility of the skin that occurs can cause little fissures like paper cuts, which again can impact on pain. And the condition itself can have big effects on day-to-day functions. So walking, sitting, exercising, anything you do day to day, and going to the toilet can be really uncomfortable. To pass urine or open the bowels can be really uncomfortable for people. And of course, as you can imagine, affecting where it is, it can really affect relationships and sex life as well for people. So the impact on function, psychosocial and sexual side of things can be really massive. But it's not just an itchy skin condition, because lichen sclerosus does have some longer term effects. And if not treated, it can cause scarring. So sticking together of the skin at the vulval area, which changes the visual appearance of the anatomy. And in severe cases, it can actually lead to some narrowing, closing up of the entrance to the vagina. Furthermore, there is a small increased risk of cancer in the affected skin of those who have LS. The figures aren't that well known, they're not that well reported, but it is believed that around 3% of women with lichen sclerosus could develop a vulval cancer. And the risk of a vulval cancer in someone with LS is around 20 times higher than someone without LS. Vulval cancer is not common, and so the numbers we're looking at are quite small, but this is a really quite serious complication, as I'm sure you can imagine.
And obviously, the sooner it can be recognised, the sooner then one can find out how to treat and manage it, and hopefully prevent further issues along the line.
That's it. Lichen sclerosus isn't that well known about amongst the general public, and actually amongst the wider health profession as well. That it isn't a really well known about condition, and part of the reason for talking to you about it today is to help raise that awareness. People don't like talking about problems in the genital area. It's embarrassing. It's still quite a taboo subject. So people often don't present to their GPs until it's quite late down the line. But also, if people do present, it's often assumed that it's thrush or irritation due to something else. So the diagnosis isn't often made till later on. And then it can take even longer for people to be diagnosed, or the primary care professional wonder if it could be lichen sclerosus and then get them to a secondary care professional who can help them. I mean, we have heard of delays in diagnosis of 10, 15 years, which is a really long time, isn't it, for something that has these serious complications that we talked about. But the important take-home message that once it's identified correctly, then around 7 out of 10 people improve with a 3-month course of topical steroid. And a topical steroid isn't a difficult treatment to use. It's a cream or an ointment that's put on the skin. So around 7 in 10 improve considerably in a 3-month period, to the point that they go into actual remission and their symptoms and signs all disappear. But LS is a long-term condition, and so it may well flare again in the future, and it's very likely that people will not stay in remission forever.
Right. And so tell me about your trial called PEARLS.
Yeah, so PEARLS is an abbreviation for a longer title, which is Proactive Against Reactive Treatment for Lichen Sclerosus. I talked about this 3-month course of treatment that gets people's signs and symptoms improved and gets them into remission, which is great. But what we don't know is what to do longer term to treat people with this condition. It's a chronic condition. It's not going to go away completely. So if someone's diagnosed in their 20s, 30s, 40s, I mean, whenever someone's diagnosed, they are going to have the condition for a long time. and it can flare up at any point. It's often there are various trigger factors that might flare it, like stress or friction or sort of irritation in the area. But it's not known what to do longer term to try and minimise these flares. And it's also not known, although it is suspected, that if we control the disease better, then the complications that I described of scarring and cancer formation can be minimised. It might not be that they can be stopped, but they could be minimised. And there's real differences in what's happening internationally on how people are treating lichen sclerosus longer term. And it's not clear when people have gone into remission, they don't have any symptoms and they don't have any visual signs of lichen sclerosus being active. It's not clear whether they should be using their steroid ointment just when they have a new flare of symptoms, or whether they should be using it in a proactive manner, and that is using it a couple of times a week to try and minimise flares and progression. And that's what the PEARLS trial is looking at. We are recruiting people to the study where they will be randomised, so they'll be allocated randomly to one group or another. And one group of people will be using their steroid ointment proactively, so that's twice a week. And then the other group will be using it reactively, which is as required to treat a flare of symptoms. And people are doing this for a 2-year period whilst in the study.
Right. So the people that you're looking for, first of all, do they have to have a diagnosis from a doctor, or could they ask you, we have these symptoms, could this be lichen sclerosus?
But the diagnosis does need to have been made, because we talked about the fact that there can be misdiagnosis. So a self-diagnosis of lichen sclerosus wouldn't mean that someone can qualify for the trial. They would need to be seen by a doctor who agrees that it is lichen sclerosus. Some people, when they're coming through our outpatient clinics, will have a little skin biopsy to help with the diagnosis. That's not a mandatory thing for the PEARLS trial, but some people in the past may have had a skin biopsy that showed lichen sclerosus and they're now in remission. Those people would be able to enter the trial. People who think they've got lichen sclerosus but it hasn't been formally diagnosed would need to be formally diagnosed before they could be accepted.
So,
and skin biopsy, sorry to interrupt you, skin biopsy isn't a mandatory thing. It's just if someone's had one in the past or it's unclear what their diagnosis is, they might need one to be able to qualify.
Right. So do they need to have the diagnosis from a healthcare profession before they apply, or is that something they could do? They just say to you, I think I've got it. Do you then do the diagnosis?
The ideal thing would be if they had a diagnosis before they applied, and it might mean that they need to see their GP for review and assessment.
Okay, so once they've signed up with you, they then are on the trial for a 2-year period, taking the medication.
That's right. So the medication is a topical treatment, so it's a cream or an ointment, as I said, using it twice weekly or using it as required. People with vulval skin conditions are also recommended to follow a good vulval hygiene program. So that's avoiding irritants and things that might make the vulval skin worse. So we usually give a moisturizer to use instead of soap or shower gel to the area. And then that can also be used as a barrier and soothing cream during the daytime if needed. So people would be able to carry on with their usual sort of moisturizer or vulval care program as well, using the steroids as directed.
And presumably that you're always available and you're fully supported in this 2-year period by the trial centre they're going to.
That's right. So when people are recruited into the study, they would have 6 visits all in all, which is actually more frequent than what many people with lichen sclerosus would be seeing a health professional, particularly if their condition has gone into remission or it's quite quiet. So people are seen at what we call baseline, then 3, 6, 12, 18 and 24 months later. And during that time, they'd be able to contact their research nurse or their managing clinician if they felt they needed a review or they'd got into trouble using their topical steroid.
Excellent. And I was just going to say, what are the benefits? But I think you've just pointed out very clearly what one of the main benefits is, that they're seeing somebody more often than they would do normally.
In some cases, that would be correct. Yes, some people are coming to outpatient clinics on a regular frequency. Other people, if, for example, they have been discharged from a dermatology or gynecology clinic, or they've just been seen by their GP, might not have been seen that often at all.
Right. And what are the other benefits people will get from taking part?
There may not be any direct benefit because, of course, we don't know what treatment routine is best, and that's what the trial is about, trying to find this out. But in terms of the longer term goals, the results from the study are going to then inform and feed into what we do in future to manage patients with lichen sclerosus. So really, taking part is informing the bigger picture. And regardless of what the results show, what we will be disseminating and putting out there at the end of the study, we hope would be internationally adopted in terms of being incorporated into guidelines and patient information.
Excellent. And I think, with Talk Health's experience with supporting, whether they be anecdotal or clinical trials, people who do suffer from these chronic health conditions are very, very keen to support that other people don't have to go through what they may have had experienced themselves.
I agree. There's a big lichen sclerosus community on the support groups, and I know you've spoken to Claire, who runs a very well-known support group in the UK. There's a big community of people who are really invested in trying to improve care for this condition. And like you say, that being involved in research really is a way of sort of feeding back to the community and making sure that things are really trying to enable things to be smoother for people in the future with their experiences.
Right. So on Talk Health, we'll be promoting all the links, and so people can go straight onto your website to read more details about it, whether they feel it's for them or not. There's also a link then for them to inquire, to express their interests, as I understand it. And presumably from there, you take over looking after people and checking how they can be supported.
That's right. There are different ways to come into the PEARLS trial. So some people will already be seen by a dermatologist or a gynecologist or a health professional in hospital. And if their site is involved in the study, they could express interest directly to their site. We are also using GP surgeries as what's called patient identification centres. So GP surgeries that are signed up to the study are going to be looking through their records to identify potential participants who will then be contacted to see if they want to take part. But then there's this self-referral route, so people finding out about the PEARLS trial through things like Talk Health, in which case there's a link to our webpage, which you can find out a bit more information about the study, and also the funding information, so because we're funded by the National Institute for Health Research. And then there is an email address in which you can contact, which takes you to the PEARLS central mailbox, which is manned by Nottingham Clinical Trials Unit, and somebody would be able to pick up the email and liaise with the potential participant, with the patient, to see if there's a site near them that they could be referred to.
Excellent. Well, thank you, Ros, and we wish you well, and we'll be supporting the trial throughout and hopefully getting lots of people through for you to be able to further the knowledge on this subject, which we know it gives great angst to many people who do have it.
Thanks very much for your time today.
Thank you.